Hello, welcome to the review on the endocrine system. There's a general rule in studying endocrinology. First, know what the hormones are produced by each of the endocrine gland. Next, you should understand what are these hormones are for, meaning the normal function. Then you will know the clinical manifestations if the hormone becomes too excessive or too little. Third, understanding how each of these hormones are regulated helps you understand the different tests. There are two general groups of glands. Exocrine glands that secretes product directly into the ducts, you're all aware of this, and your endocrine glands that secretes products into the blood system. There's the whole endocrine system whereby there's an HPO axis that we talk about. Thymus, generally, this is for immune system, and not part of this module. And the ovaries and testicles will be discussed further in gynecology and urology. So we'll focus on the hypothalamus and the pituitary, the parathyroid gland, the thyroid gland, adrenal glands, and of course the pancreas. The main function of the endocrine system is to integrate, regulate, and coordinate a lot of body action. So there's an interplay, cross-talking of all these different hormones to keep your organs going. So it's important for maintaining homeostasis, as you know, for reproduction, growth and development, and also metabolism. We also have stressors like catecholamines and cortisol. And of course, fluid for antidiuretic hormones, electrolyte balance, calcium, sodium, and potassium are all regulated by hormones. Hormones are generally present in very low amounts, so the units are either micrograms, nanograms, or picograms. And the hormones generally act as keys, and you have receptors that respond to these hormones, which are locks. And generally, they are quite specific. That certain hormones can open certain locks only, with some exceptions. You have two general groups of receptors, the intracellular receptors, which are in the nuclear membrane, and your surface receptors in the cellular membrane. Obviously, for the hormone to cross, they have to be lipophilic. So for nuclear receptor, the hormones attached to them are lipophilic hormones. So if you're going to memorize, just memorize the ones on the right side. Thyroid, steroid hormone, including estrogen, testosterone, cortisol, vitamin D's, and vitamin A's. These are the three general groups. The steroid hormones, thyroid, and the vitamins are the ones that are lipophilic and crosses the cellular membrane to reach the nuclear membrane where the receptors are located. Receptors are generally specific, like I said. However, there are certain situations whereby there's going to be cross reaction at very high levels. One example is beta-HCG that shares the same alpha subunit as TSH, LHM, FSH. At very high levels of beta-HCG, for example, first trimester of pregnancy or during an HMO pregnancy, there could be hyperthyroidism. So normal levels, low levels of beta-HCG during pregnancy should not be a problem, but at its peak or in HMO pregnancy, it may behave like TSH and attach to the TSH receptors of the thyroid gland and cause hyperthyroidism. Another common example is, although the main mineralocorticoid considered in our body is aldosterone, cortisol is equally potent in attaching to the mineralocorticoid receptors, exerting the same effect, supposedly. However, at the levels of the kidneys in the tubules where the mineralocorticoid or aldosterone has its most of its action, there's an enzyme called 11-beta-hydroxysteroid dehydrogenase 2 that breaks down the cortisol, so breaking down the mineralocorticoid effect of cortisol. However, this is important in hypercortisolism, whether endogenous or exogenous hypercortisolism. There's a possibility of too much cortisol in the system that it overwhelms this enzyme. So you're going to have a spill of this cortisol, that the enzyme can no longer handle. So therefore, the cortisol now starts to have mineralocorticoid effect. That's why there is hypertension and also hypokalemia in a case of hypercortisolemia. Let's talk about hormone regulation. Hormone regulation can be regulated at the level on how it's formed. Once formed and stored, it can be regulated at the level of how much will be secreted, and once secreted, how they're going to be transported, and eventually how they're going to be eliminated or metabolized. Most of the hormones are regulated by negative feedback within the same endocrine gland that secretes and regulates a particular hormone. There are receptors that will detect that whether you're having too much or too little already. So therefore, the endocrine gland will now have to decide whether it's going to shut down or produce more, depending on the circulating hormone itself. So if there's an increased hormone, for example, thyroid hormone, by negative feedback, there's going to be a shutdown of TSH and TRH. Therefore, there'll be less stimulation, further stimulation of the thyroid gland. And the same is true. If there's a drop in thyroid hormone, there's going to be a loss of that inhibitory feedback. Therefore, the whole system will be activated and the thyroid gland will be stimulated now to produce thyroid hormone. So generally, what can go wrong with the endocrine gland? There are only three things that can go with any endocrine gland. You just have too much of that hormone, too little of that hormone, or too little effect of that hormone is also a possibility. And of course, the enlargement of an endocrine gland. So each of the endocrine gland, as we go through them, just think about too much, too little, or too big. And if they're too big, is it diffuse or nodular? And if it's nodular, you think about the possibility of benignity, or malignancy. Hormone excess may be due to excess of stimulator or deficiency of inhibitors. It could be autonomous. They just without the effects of its regulatory hormone, it just keeps on pumping and producing more hormones on its own autonomously. Of course, some hormones more than the others can be abused in excess by intake exogenous. Some common examples are steroids and also thyroid hormone, because they are cheap and they are available in tablet forms, oftenly either as part of treatment for other diseases, or accidental overdose is a possibility. On the other hand, hormone deficiency may be due to lack of stimulator or excess of inhibitors. For example, in secondary hypothyroidism, if your pituitary is destroyed, TSH won't be able to stimulate your thyroid gland to produce thyroid hormone. Next is destruction of the hormone producing cell itself. For example, mass effects. If the endocrine gland is compressed, there's going to be a malfunction. Infarction, for example, in Sheehan's, there's going to be destruction of the pituitary. Infiltration of the thyroid gland by lymphocytes, for example, in Hashimoto's thyroiditis, can cause malfunction of the thyroid cells. Autoimmune destruction, these are example is type 1 diabetes, for example. And surgical removal in thyroidectomy. Receptor resistance, an example of this is type 2 diabetes, or testosterone resistance, whereby there's a condition called testicular feminization. So these are several ways by which the hormone or the effects of it might become low. Endocrine gland, like we said, can be diffuse versus nodular. Anytime we detect endocrine to have some kind of a nodule, then the concern is whether it's hormonally functioning or not. Not all nodules within the endocrine gland are hormonally functioning. And if they are non-functioning, you want to determine where it's coming from, or it's typically a tumor of the supporting tissues of the endocrine gland and not the hormone producing cells of the endocrine gland. Then, of course, mass effects. You ask always about the possibility of pain and tissue compression. So, in the case of if you have an enlargement of the pituitary, you worry about bitemporal hemianopsia and also headaches. In the case of thyroid gland, you worry about dysphagia, dysphonia, and dyspnea. So think about what are the effects of the enlargement of a particular endocrine gland and how they will manifest. First, let's talk about the master gland, the anterior pituitary gland. It is typically only about 10 to 20, only about 10 grams in weight, really small. And the anterior pituitary gland has 6 different hormones. We'll go through them one by one. The posterior pituitary hormones has two, and the difference is the anterior pituitary hormones are actually produced by the anterior pituitary gland. Posterior pituitary hormones are not. They are produced higher up in the paraventricular nuclei and supranuclear um, nuclei, supraoptic nuclei above in the hypothalamus and just passed down via long axons and stored in the posterior pituitary. So this is the typical HPO axis. Not all the anterior pituitary hormones follow this, but generally four, uh, particular the three rather, the thyroid hormone regulation, the cortisol production by the adrenal cortex, and the gonads in terms of spermatogenesis and also testosterone, estrogen production in female are regulated by the hypothalamic pituitary end organ axis. So you have your hypothalamic hormones. Each of those anterior pituitary hormones are regulated in some ways by some another hormone from the hypothalamus. So let's take, for example, the thyroid gland, TRH, and then it stimulates the anterior pituitary hormone to secrete TSH, and the TSH will be secreted, and once it reaches the receptors within the thyroid gland, it will stimulate the thyroid gland to take up more iodine and produce more thyroid hormone and release them. And we'll go through this one by one. So each of those have their own purpose. So for the ovaries, it's estrogen, progesterone production in terms of the cycle and regulation. So 6 hormones that we're going to talk about: prolactin, growth hormone, ACTH, TSH, and then we'll take LH, FSH together. So again, generally know the function of each hormone. Then you will know the manifestations of too much, too little, and we'll talk about them one by one. So prolactin, generally no clear role for men or non-pregnant female. It's primarily for lactation. So in pregnancy, it acts to induce and maintain lactation, reduce reproductive function by suppressing GnRH. So one of the reasons why uh, women starts menstruating during pregnancy is because of increase in prolactin shutting down your GnRH. And the regulation from the hypothalamus is unique, that it's mainly inhibitory by dopamine. So for all the other remaining anterior pituitary hormones, the influence from the hypothalamus is a stimulatory one. This is one exception. Prolactin, it's inhibitory by dopamine from the hypothalamus. That's why dopamine antagonists can cause prolactin to go up. The treatment for hyperprolactinemia is dopamine agonist. So let's talk about hyperprolactinemia. This by too much prolactin, it shuts down the GnRH. Therefore, in women, there could be amenorrhea, galactorrhea because it induces breast tissue, and infertility in women. In men, there could be lost libido and infertility. The Physiologic cause of hyperprolactinemia is pregnancy, during lactation. It also goes up during sleep and chest wall stimulation. Pathologic includes prolactinoma, but one needs to rule out in the evaluation of hyperprolactinemia, you need to rule out drugs such as dopamine antagonists used by psychiatrists. And also one need to rule out primary hypothyroidism. TRH at normal levels does not affect prolactin, but if you have primary hypothyroidism, when thyroid hormone goes down, TRH can go just high enough to stimulate prolactin production. That needs to be ruled out. So every single patient that presents with hyperprolactinemia, once you've ruled out medication, they should undergo a test for thyroid function. So very simple, we just do a morning basal, morning prolactin for these patients. Generally, exception number 2 for prolactin is for all the other hormones of the anterior pituitary, the size does not correlate with the amount of the hormone excess in the blood. For prolactinomas, there is a good correlation. And generally, a prolactin level more than 200, you're almost sure this is a pituitary adenoma. And for prolactin levels more than 500, it's going to be a macroprolactinoma, meaning more than 10 millimeters. And if your prolactin level is less than 100, generally these are either really tiny prolactinomas or could be just drug-induced or impingement of the pituitary stalk. Say, for example, there's another tumor there not related to the pituitary, and it impinges on the pituitary stalk. There's a possibility of the dopamine not being able to cross through, so prolactin level might go up a little bit. So the main treatment, exception number 3 for prolactinomas, they respond very well to medication. So bromocriptine, cabergoline are dopamine agonists. For all the hormone-producing pituitary tumors, they are surgical, except this one because they respond very well to dopamine agonists. Surgery and radiation is really safe for rare resistant cases. So let's go to low prolactin. Generally, you wouldn't know that you have low prolactin because there's no consequences in men, and unless a woman is not if a woman is not lactating, they wouldn't know that they lack prolactin. Only, for example, in she-hens, there's a infarct of the pituitary where prolactin goes down, and that after they deliver, they won't be able to lactate. Then they'll know that prolactin went down. However, one needs to know that if you have lack prolactin, just in case, and the question is, do you lack any other anterior pituitary hormone? Next, I talk about the growth hormone. So growth hormone has direct effects. We know it's mainly for growth, and it has metabolic effects like glycogenolysis and gluconeogenesis. So therefore, one can understand that if you have really high levels of growth hormone, like in gigantism and acromegaly, glucose might just go up. Most of the tissue effects of growth hormone is through IGF-1. Within the liver, there are receptors for growth hormone, and if your growth hormone goes up, the liver will be stimulated to produce IGF-1. It's the IGF-1 that exerts the majority growth-promoting effects of growth hormone. But growth hormone does have direct growth-promoting effects. It's pulsatile, highs at night, especially when you sleep. If you remember, your parents say you won't grow tall if you don't sleep at night. And there's probably some truth to that because the spikes, the number of spikes and the peak of the spikes is at night when one sleeps. IGF-1 produced by the liver has negative feedback on the anterior pituitary to prevent further growth hormone secretion. So let's talk about growth hormone excess. So there are two terms, gigantism or acromegaly, depending on whether the epiphyseal growth plates are still open or not. If your epiphyseal growth plates are still open, meaning during teenage years, and the growth hormone goes up, you'll have really tall kids. And but if the growth hormone excess happen after the epiphyseal growth plates are closed already, then what you won't have linear growth, but you'll have prominence, broadening, widening of bones, and soft tissues. So generally, they manifest as coarsening of facial features, enlargement of glands, enlargement of sweats and sebaceous glands, or they're sweaty, they're oily, and also because growth hormone is one of the counter-regulatory hormones for insulin, there's an increase for diabetes. The most common cause of acromegaly is a growth hormone secreting pituitary tumor, more than 98%. Less than 1% are all the other causes like a hypothalamic GHRH or sometimes ectopic growth hormone secretion like in the pancreas, pancreatic tumor, for example. Those are extremely rare. So once we confirm biochemically the patient has growth hormone excess, we go after the pituitary because more than 98% of the times it's going to be in the pituitary. So this is what we do. Generally, growth hormone, whether it's growth hormone excess or growth hormone deficiency, we do not check growth hormone blood level because growth hormone in itself is pulsatile and it has a very short half-life. Therefore, there's a extreme. It's hard to catch the peak or the nadir of the growth hormone because of its short half-life. Since the effects of growth hormone is towards IGF-1, and IGF-1 having a longer half-life represents more represents the true amount of pulsatility or amount of growth hormone around. So in the case of growth hormone excess, the one that you screen for is IGF-1. And the biochemical confirmation, there's one rule in endocrinology that if you have too much of a hormone or you suspect that the patient may have too much of a hormone, the test that you go for is a suppression test. If you suspect that there's a deficiency of a particular hormone, you'll try to stimulate it, and that's kind of common sense. So in the case of growth hormone, we know that if glucose goes up, it's supposed to go down, and if the glucose goes down, it's supposed to go up because it's one of the counter-regulatory hormones that prevents us from becoming hypoglycemic at night. So if you're not eating, glucose starts to go down to prevent further hypoglycemia. Besides glucagon, catecholamines, and cortisol, growth hormone is another hormone that prevents us from becoming hypoglycemic at night. So it can promote glucose to go up. So if you have too much of that hormone, sugar might go up. So to try to suppress growth hormone, you give the patient glucose. It's supposed to go down. It did not. Then you have excess. Then after which you go for it go after it with an MRI. Surgery is the mainstay, and you can give octreotide, a somatostatin analog, or a growth hormone receptor antagonist called pegvisomant to control further growth hormone in the circulation. In the case of deficiency, we also use IGF-1 as screening. And the gold standard is to try to stimulate it by making the patient hypoglycemic this time by infusing insulin. And once confirmed, the treatment is subcutaneous growth hormone injection. Next, let's talk about ACTH. It peaks at 6 a.m. and lowest at midnight. So it follows that the cortisol is highest in the morning, lowest at midnight. And it follows this negative feedback also. So let's talk about too much ACTH excess. If if ACTH is high autonomously, then it will keep on stimulating the cortisol production. So what you're going to have is Cushing syndrome, which means a constellation of excess fats like moon fascia, facial protera, supraclavicular fat pad, central obesity, and because cortisol has some kind of proteolytic effects, the skin will become thinner, you lose some muscles, and so therefore there's going to be proximal muscle weakness. And in the case of osteoporosis, it activates osteoclasts, so therefore there's going to be thinning of bone. We already said that Uh, Diabetes can happen because it's one of the counter-regulatory hormones. Hypertension can happen because of overwhelming the enzyme that breaks it down. So therefore, it starts to have some mineralocorticoid effect, just like aldosterone. But normally, at normal levels of cortisol generally do not cause mineralocorticoid effects. Most common cause is uh, uh, Cushing's disease means an ACTH-producing pituitary adenoma. Cushing's syndrome means constellation of the manifestations of excess cortisol. When we say Cushing's disease, we are specifically talking about an ACTH-producing pituitary adenoma. And this is the most common cause of endogenous Cushing syndrome. If you're asked on the board exam, what's the most common cause of Cushing syndrome? The answer is exogenous. If the question asks what's the most common cause of endogenous Cushing syndrome, the answer is Cushing's disease. So how do we screen for excess cortisol? It's either doing an overnight 1 milligram dexamethasone suppression test, measure a 24-hour urine-free cortisol, or measure a 12 midnight salivary cortisol. Why midnight? It's supposed to be at its lowest point at night. If the cortisol from saliva is elevated at midnight at its lowest point, then that's one of the screening tests for hypercortisolism. And once you have hypercortisolism, then you have to differentiate whether it's ACTH dependent, meaning is the excess cortisol being produced by the adrenals is due to a high ACTH from Cushing's disease or some ectopic ACTH, or is it ACTH independent, meaning the problem is an autonomous problem at the level of the adrenal cortex. And depending on the result of the ACTH you choose, are you going to do an MRI of the pituitary or are you going to do a CT scan of the adrenals? ACTH producing tumor, if it's from the pituitary, generally we do a transsphenoidal surgery. And to temporize the effects of hypercortisolism, you can block the formation of cortisol at the level of adrenal cortex using these different medications in red. ACTH deficiency causes secondary adrenal insufficiency. So when in endocrinology, when we say primary something, we are talking about the end organ. When we talk about secondary, then we're talking about the where we are talking about the regulating organ. So in the case of if your deficiency of cortisol is due to a deficiency of ACTH, then the terminology is secondary adrenal insufficiency. And this comes in different forms. Sheehan's can also cause Sheehan's syndrome, for example, infarct of the pituitary during childbirth can destroy the pituitary to cause secondary adrenal insufficiency. Autoimmune destruction is also a possibility. So very important, very common question. The last bullet is, unlike in primary adrenal insufficiency, mineralocorticoid aldosterone, since it's not regulated by ACTH, it's not affected. Okay, and hyperpigmentation is absent in secondary adrenal insufficiency. So again, when we go to adrenals, we'll talk about this again. Okay, so if your adrenal insufficiency is due to a pituitary cause, aldosterone won't be affected. And to stimulate cortisol production, and one can also, just similar to growth hormone deficiency, one can do an insulin tolerance test for that. So the ITT can actually accomplish and measure deficiency of two hormones, the ACTH and also the growth hormone. TSH, stimulating hormone, we know what it's for. This negative feedback is very sensitive, that TSH is the single best screening test. We'll touch upon this when we go to thyroid gland again. So this is the HPT axis. A true TSH excess, so the most common cause of an elevated TSH is not a TSH producing adenoma. It's the most common cause of an elevated TSH is the pituitary responding to hypothyroidism. So if you have primary hypothyroidism, naturally the normal function of the anterior pituitary TSH is supposed to go up. However, a true TSH excess to TSH producing adenoma is extremely rare. So we know that if the pituitary keeps on pumping TSH, then what's going to happen is you're going to have hyperthyroidism. Okay, they tend to be big. So you suspect a TSH producing pituitary adenoma is if you have high thyroid hormones, yet your TSH by negative feedback supposed to be low did not go down. It remained normal or very high. Then if they're all high going in the same direction, it doesn't make sense because there's supposed to be negative feedback. If that doesn't happen, then you suspect that there might be a TSH producing pituitary adenoma. And the main treatment is surgical. So while waiting for surgery to happen, you can give anti-thyroid drugs and beta blockers to temporize the excess thyroid hormone production. A low TSH, on the other hand, if you see this, the most common cause is primary hyperthyroidism, like Graves' disease. And one needs to interpret thyroid function tests paired together with the thyroid hormone itself. So a true TSH deficiency or secondary hypothyroidism is suspected if one has low T4 or T3. Then you have inappropriately low or inappropriately normal TSH. It's supposed to go up, it did not. There's something wrong with your pituitary. And there are different causes. If they're treatable, you treat it. If it's not treatable, you just give patients thyroid hormone. LH and FSH, you know very well how important they are, both in female and male, in terms of regulating ovulation and also menstruation. In the case of men, for spermatogenesis and testosterone production. So, kind of easy for female. FSH stimulates estrogen production and promotes follicular development. LH, on the other hand, is important. The LH surge is important for ovulation and maintaining the corpus luteum if the woman gets pregnant. For men, FSH, remember SSFS is for spermatogenesis. LH is for the other one, testosterone production. However, the negative feedback from LH-FSH is unique. It's not a pure stimulatory. You know very well that it's estrogen that causes LH surge. So in some ways, this negative feedback is not pure negative feedback. There's some positive feedback. And this is the reason why, for example, if you have too much LH and FSH, like in gonadotropic hormone-producing pituitary tumor, generally what happens is you don't have become a superman or superwoman. The same thing happens, just like deficiency of LH and FSH. If you have too much and constant pumping of LH, FSH, the whole system shuts down. So just like I said, because of its fine-tuning of entry and exit of LH and FSH, if you have too much and they're just there all the time, you manifest with the hypogonadism rather than too much sex hormones. They tend to be big also. On the other hand, you have deficiency. This is what we call hypogonadotropic hypogonadism. You have low level of estrogen, and by loss of negative feedback, LH, FSH is supposed to go up. It did not. In somebody with low estrogen or low testosterone, then you say there's something wrong with the pituitary. So treatment, just to have libido in men and hair growth, you give testosterone. But giving testosterone will not make the patient have spermatogenesis. There's other fine tuning. There should be pulsatility because you need to stimulate spermatogenesis by giving the right amount of GnRH. Same thing with female. By giving estrogen and cycling with progesterone, you can make them menstruate. However, that doesn't mean they're ovulating. So for patients with LH, FSH deficiency, you have to give them GnRH in pulsatile fashion to improve their fertility. So posterior pituitary gland, very fast on this. Okay. We said it's a ventral extension of the hypothalamus, not produced in the posterior pituitary, and the source is up in the hypothalamus, paraventricular and supraoptic nuclei. There are two hormones, oxytocin and arginine, vasopressin, or Um, Functional name is antidiuretic hormone. They mean the same. Arginine vasopressin is the biochemical name, and antidiuretic hormone is the functional name, but they're the same thing. Oxytocin is important for contracting myoepithelial cells surrounding the mammary gland for milk letdown. Also for important for contraction after labor to contract the uterus. Generally, excess has not been clearly demonstrated, but deficiency may cause difficulty in nursing or also atony of the uterus postpartum. AVP or ADH, they work primarily in the V2 receptors of the distal convoluted tubule to decide whether water will be reabsorbed or not. Okay, and is largely regulated in the central nervous system by osmolar receptors. So 1% change in osmolality can either increase or decrease your antidiuretic hormone. So if you have increased osmolality, increase osmolality to dilute it, you will trigger the antidiuretic hormone. And the opposite is true. There are basal receptors within the atrium that also triggers antidiuretic hormone. Obviously, if your blood pressure goes down, the baroreceptors will be triggered to reabsorb water to help improve your blood pressure. This is one of the mechanism by which blood pressure is maintained. However, this is not as sensitive as the osmolality. It takes a few more percentage change in blood pressure before antidiuretic hormone will be activated, unlike osmolality. And there are V1 receptors within the smooth muscles that causes vasoconstriction. So the very last hope sometimes cardiologists or doctors will give antidiuretic hormone to improve the blood pressure, but they're not as good as dopamine or norepinephrine in increasing the blood pressure, but they are used sometimes. So diabetes insipidus is too much. Diabetes is meaning urine, okay, and insipidus is too much. So generally they produce more than 3 liters of very dilute urine because of lack of antidiuretic hormone. So you cannot. So we call it central DI if the problem is a defective secretion of antidiuretic hormone, and it's called nephrogenic if the problem is there's enough antidiuretic hormone, but the tubules, distal tubules receptor are resistant to it. So pretty much central DI is like type 1 diabetes, whereby you don't have hormone itself. Nephrogenic DI is like type 2 diabetes, where there's a resistance of an existing antidiuretic hormone. So how do we test? So if you suspect the patient is having diabetes insipidus, meaning inappropriate or lack of the effect or lack of amount of antidiuretic hormone, we do a water deprivation test, and we measure the urine and serum osmolality. In patients, normal people, if we water deprive you naturally, you're going to start to try to trigger antidiuretic hormone, and you're going to have more concentrated urine. Not in patients with diabetes insipidus. They will continue to excrete dilute urine despite water deprivation. And at the end of the test, we'll try to inject desmopressin. If the patient starts to concentrate, that means there's nothing wrong with the distal tubule. You have deficiency of the antidiuretic hormone. So then the diagnosis will be central diabetes insipidus. If despite injecting exogenous antidiuretic hormone, the kidneys does not respond, they continue to excrete dilute urine, then the diagnosis is a nephrogenic DI. So how about excess of antidiuretic hormone? And if you have too much antidiuretic hormone in many conditions like stroke or lung infection, this is what we call a syndrome of inappropriate antidiuretic hormone. So if you have too much water in your system, then the manifestation will be hyponatremia. Next, let's talk about the thyroid gland. This is a general anatomy. You have 4 parathyroid gland hiding behind it. That's why sometimes the surgeon should be very careful when they're doing thyroidectomy not to remove the parathyroid glands, otherwise the patient will become hypocalcemic. So it's generally located in the anterior middle lower part of the neck. It's a butterfly organ. This is a cut section whereby thyroid follicles, follicular cells are lined up into one follicle, so it's kind of confusing, but Each of these cell, tiny cuboidal cells, are called thyroid follicular cells, but once they are lined up, one circle is called a thyroid follicle. And this is where thyroid hormone is being produced. So thyroid hormone production comes in different forms. There are different stage. Iodine has to be ingested. That's why iodine deficiency causes hypothyroidism. It will be circulated in the capillaries and then transported within the cells. There's a receptor for this called the sodium iodine symporter, taking up into the thyroid follicular cells. It'll be then oxidized, incorporated to the uh, tyrosine amino acid within the thyroglobulin. This is where all the thyroxine are floating, and then it'll be incorporated to it. Then you form MIT or DIT. MIT is monoiodotyrosine, DIT is diiodotyrosine. Then there's going to be coupling. And coupling between MIT and DIT, 1 plus 2 will give you T3. Coupling of two DITs will give you T4. And then once stimulated and ready, if needed, the thyroid gland will be proteolyzed. It will be released into the circulation. So you have two different cells within the thyroid gland. Your follicular cells, we talk about this. It's primarily for producing thyroid hormone, and you have your parafollicular cells producing calcitonin. Supposedly, calcitonin exerts the exact opposite of the effects of parathyroid gland, but generally it plays very little role on calcium metabolism because in disease like medullary thyroid cancer, where calcitonin goes up, calcium level generally does not change. And if one undergoes total thyroidectomy, as long as the parathyroid gland is left behind without the parafollicular cells, even with total thyroidectomy, and your calcitonin goes down, the calcium level won't change. So we know that generally whether calcitonin goes up or goes down in vivo, clinically, physiologically, it plays very little role in calcium metabolism. And it's pretty mostly affected by parathyroid gland and vitamin D, the calcium level. And we'll talk about that when we go to the parathyroid. So there are two different hormones of the thyroid, T4 and T3, and just to differentiate, and these are knowledge that you will use as a clinician. So T4 is 100 produced by the thyroid gland. T3 is only 20% produced by the thyroid gland. 80% of your T3 comes from T4, okay? And it has clinical relevance. Let's talk about T4 first, being 7-day half-life. So 7-day half-life is important. It's very long half-life. Therefore, generally in pharmacology, you don't consume a drug until 4 or 5 half-lives. You do not reach a new steady state until 4 or 5 half-lives. It is important to know that if you undergo total thyroidectomy, the next day you will not become hypothyroid. So do not panic. And if you are giving thyroid hormone to patients, uh, titrating up and down on your exogenous thyroid hormone, if they're hypothyroid, you have to wait about 4 to 5 weeks until they reach a new steady state before you repeat a thyroid function test. Okay, that's for the T4. So T3, why is it important that only 20% comes from the thyroid gland? And this is the reason why knowing that 80% majority, the T3 is the more active hormone, 80% comes from T4. So generally in patients with hypothyroidism, the tablet that we give is only T4, not T3. The body will just convert it to the more active T3. It has shorter half-life. It's more potent. It's the real thyroid hormone. T4 generally is considered to be a pro-hormone. It's important that there are certain medications, for example, in hyperthyroidism or thyroid storm, we intentionally block the conversion of T4 to T3 because we know that majority of T3 comes from T4 and T3 is more active. So if in extreme cases, you have to block the conversion of T4 to T3. So normal function, we know this very well, basal metabolic rate. So that's why there's a lot of heat produced if you have hyperthyroidism, and it plays a permissive role in growth and development. That's why there's cretinism that we talk about. The patient won't grow if you don't have enough thyroid hormone, and also infertility. Count on it. Obstetrician, any woman that comes to their clinic for infertility, they'll check their thyroid function because your thyroid hormone has to be perfect for estrogen, progesterone, and the pituitary to work properly. So this is how it's regulated. Okay, the negative feedback is a very sensitive one, so it's very it is a cartoon only that if FT3 FT4 goes down by response, TSH supposed to loss of negative feedback, TSH to supposed to go up. But notice the fulcrum is very near T4 T3, so tiny changes of FT3 FT4 will swing your TSH to the opposite side. That anytime you have mild abnormality, TSH will be the first one to become abnormal. The same thing is true though during the treatment of hypothyroidism and hyperthyroidism. TSH will be the last one to become normal because you have to have perfect circulating thyroid hormone for the pituitary to be perfect. So making TSH the single best screening test. So what can go wrong with the thyroid gland? You have too much or too little um, of thyroid hormone, and too big in size we call goiter. Let's go through this fairly quickly. So thyroid hormone excess is called thyrotoxicosis, and we'll talk about the two kinds of thyrotoxicosis. The more general term is excess is thyrotoxicosis. Obviously, it can be due to too much TRH, too much TSH, but those are extremely rare. The most common cause of thyrotoxicosis is primary thyroid gland disease, like Graves' disease and toxic adenoma, and the like. We'll talk about that in detail. So manifestations, you have increase in basal metabolic rate, so therefore they're going to lose weight. You're going to have increased production of heat with the body trying to normalize temperature. You're going to sweat, and and because of the increased basal metabolic rate, the patient will commonly become hungry pretty commonly. And because of the increased sensitivity of the catecholamine receptors due to excess thyroid hormone, the patient will have tachycardia and sometimes atrial fibrillation, or they'll have tremors. Hello, welcome to the review on the endocrine system. There's a general rule in studying endocrinology. First, know what the hormones are produced by each of the endocrine gland. Next, you should understand what are these hormones are for, meaning the normal function. Then you will know the clinical manifestations if the hormone becomes too excessive or too little. Third, understanding how each of these hormones are regulated helps you understand the different tests. There are two general groups of glands. Exocrine glands that secretes product directly into the ducts, you're all aware of this, and your endocrine glands that secretes products into the blood system. There's the whole endocrine system whereby there's an HPO axis that we talk about. Thymus, generally, this is for immune system, and not part of this module. And the ovaries and testicles. Causes of thyrotoxicosis includes hyperthyroid causes and non-hyperthyroid causes. What does it mean to be hyperthyroid? It means new thyroid hormones is being synthesized. Why do we differentiate? Because if you have a hyperthyroid cause of thyrotoxicosis, antithyroid will work. Metimazole, PTU, and carbimazole will work because that's how they work. They shut down the thyroid gland they prevent the thyroid gland from producing new thyroid hormone. So they work. Graves' disease is an autoimmune stimulation of thyroid gland. We'll talk about the bold ones because they're the more common ones. We said TSH producing adenoma is extremely rare. Then you have cross-reactivity from beta HCG at the end of first trimester or a trophoblastic pregnancy. Then once in a while you encounter, or very rarely actually, struma ovarii. These are ectopic thyroid tissues. Non-hyperthyroid are causes of thyrotoxicosis whereby no new hormones are being produced. Therefore, thionamides like pentimazole plays no role in these particular diseases. Leakage of thyroid hormone, stored thyroid hormone, are the subacute thyroiditis and painless thyroiditis, or rarely suppurative thyroiditis, or it could be exogenous. These are the non-hyperthyroid causes of thyrotoxicosis. First, let's talk about Graves' disease. The most common cause of hyperthyroidism is Graves' disease, autoimmune. This is due to thyroid receptor stimulating antibody called TRAB. This is what we request for in the laboratory. Another name for it is TSI, thyroid stimulating immunoglobulin, just in case it comes out to the on the exam. And you have a diffusely enlarged thyroid because every single thyroid follicular cell has a TSH receptor. The autoantibody TRAB mimics the action of TSH, so the thyroid receptor, TSH receptor, think that it's TSH attaching to it, when in fact it's the autoimmune antibody stimulating it. So what's specific for Graves' disease is exophthalmos and dermopathy, pretibial myxedema. This is not present all the time. They're present only in few percentage. Majority of patients don't have it. However, if you see them, you're pretty sure it's Graves' disease because all the other causes of thyrotoxicosis generally do not give you exophthalmos or dermopathy. Excess thyroid hormone can give you a stare or lead lag, in Tagalog, dilat. But exophthalmos is lumuwa yung mata, is kind of specific for Graves' disease. So if you see this, you're pretty sure it is Graves' disease. So in Graves' disease, generally, if there's a stimulation of new thyroid hormone, remember we said that only 20% of T3 comes from the thyroid gland. Majority are from peripheral deiodination of T4. But if you have a hyperthyroidism, both T4 and T3 are being stimulated, and for some reason, T3 are stimulated much more than T4. So the increase in T3 is disproportionately higher than the increase in T4. Okay, so by negative feedback, TSH is supposed to be suppressed. Since new thyroid hormone is being produced, if you give the patient some iodine, in this case radioactive iodine, a test, the thyroid gland will suck up a lot of the radioactive iodine because it's iodine. You need more raw material if you're producing new thyroid hormone, therefore the uptake is going to be elevated. And since every single thyroid follicular cell is being stimulated, the scan, you see a nice dark picture of the pituitary, of the thyroid gland. Treatment, medical, you give antithyroid because it's new hormone being produced. Drug of choice is metimazole. Number 2, it's metimazole. Number 3, it's metimazole. Okay, PTU is less effective and it has more side effects. So to temporize the adrenergic symptoms, we give beta blockers. In extreme cases, like thyroid storm, for example, we will choose specifically propranolol because among the beta blockers, propranolol is the one that blocks the conversion of T4 to the more active T3. So we said it's metimazole, drug of choice, unless, okay, 3 conditions whereby PTU will be preferred over metimazole. 1, first trimester of pregnancy. Metimazole is more teratogenic than PTU, so therefore, during the first trimester of pregnancy, PTU will be preferred. In thyroid storm, PTU compared to metimazole can block the conversion of T4 to T3. It's an emergency, therefore, since it can block the conversion of T4 to the more active T3, it's preferred. Third, if you've already tried metimazole, the patient has some allergy or GI upset to metimazole, that's the only time you use PTU. So remember these 3 indications of PTU over metimazole. But otherwise, for most of the patients, it's metimazole. Why do we care about differentiating patients with hyperthyroidism versus non-hyperthyroid causes? Is because in non-hyperthyroid causes, do not give them thionamides. Thionamides have rare but potentially fatal side effects, just like hepatitis and agranulocytosis. Okay, so for example, if the patient is thyrotoxic due to exogenous thyroid hormone, the treatment is either to stop or reduce the dose. Do not give these patients metimazole. It doesn't make sense. Okay, the patient's already hypothyroid. There's nothing to shut down. If there's a leakage, there's no new hormone being produced, so therefore there's no role for thionamides. So don't expose your patients to unnecessary thionamides because it has rare but potentially fatal side effects. So another treatment for Graves is radioactive iodine. So we melt it down by giving higher doses of radioactive iodine because it has beta particles. It can destroy the thyroid gland over weeks. So hypothyroidism is a desired side effect. Okay, so if you just make them euthyroid, after a few years they'll become hyperthyroid again because the autoimmune antibody is still there. So we want them to be permanently hypothyroid for most cases by giving higher doses of radioactive iodine. Same thing with surgery. We rarely do surgery, uh, but if you do ask the surgeon to operate on a patient, we want them to become hypothyroid. If you leave enough thyroid tissue, years later they become hyperthyroid again. But generally, they're safe for patients who doesn't want radioactive iodine or have contraindication for antithyroid, or if they have a good size goiter, then maybe radioactive iodine won't work for those. So you have to do surgery. Next is toxic adenoma. This is not autoimmune. These are autonomous, either one or multiple. For some reason, the patients have tendency to form nodules, and these nodules are autonomous. They don't care what the TSH telling it to do. It just keep on pumping thyroid hormone on its own. So since new thyroid hormone are being produced, the radioactive iodine uptake is going to be increased because iodine is a raw material. But when you do a scan, it's going to show you hot nodules, okay, dark nodules, not a diffuse one, unlike in Graves' disease. We like radioactive iodine as treatment, of course, to temporize while waiting for the radioactive iodine. Uh, we give them antithyroid to make them euthyroid first before delivering the radioactive iodine. And while waiting for thyroid hormone to go down, you give them beta blockers to temporize their or alleviate their adrenergic symptom. Um, Hypothyroidism due to radioactive iodine is less common with toxic adenoma. You have to understand in Graves' disease, every single thyroid follicle is being stimulated. So once you deliver the radioactive iodine, each of those thyroid follicular cells will take up radioactive iodine. So therefore, they may die. In the case of toxic adenoma, all the thyroid hormone is being produced majority by the toxic nodules. So therefore, only the nodules will take up the radioactive iodine. The normal thyroid tissues are generally sleeping, so they won't take up radioactive iodine. So it will only melt the toxic adenoma or multiple adenoma. So those two are the common causes of hyperthyroid causes of thyrotoxicosis. Let's talk about non-hyperthyroid causes of thyrotoxicosis. Subacute also known as the Corvains, is viral. Uh, Typically, anytime patients comes with thyrotoxicosis, we ask them about recent sore throat or upper respiratory tract infection. If they do, and they have a very tender to touch thyroid gland, then the diagnosis will be subacute thyroiditis. The cause of thyrotoxicosis here is not new hormone production. There's leakage of stored thyroid hormone. And in fact, the thyroid gland will shut down for a few weeks. That's why there's a hypothyroid phase of subacute thyroiditis, in which case, because no new thyroid hormone is being produced and the thyroid cells are inflamed, radioactive iodine is going to be extremely low. Treatment is directly generally towards pain relief with steroids or aspirin, beta blockers for the adrenergic symptoms. Antithyroid medications plays no role. Don't make a mistake of giving thionamides to this patient. It will not, there's nothing to shut down. And if the patient becomes hypothyroid symptomatically during the hypothyroid phase, temporarily you might give this patient thyroid hormone. Painless thyroiditis is just like subacute thyroiditis but without the pain. The pathophysiology here is not too clear, but they think it's autoimmune rather than viral. And the variant of this, if it occurs within 2 to 6 months after delivery, then we call this a postpartum thyroiditis. Okay, and then generally it might recur during their subsequent pregnancies. So okay. Treatment is similar to subacute thyroiditis, except you don't have to give aspirin or steroids to control the pain. Okay. So give the beta blockers to control the adrenergic symptoms. Give thyroid hormone if during the hypothyroid phase of this disease, the patient is symptomatically hypothyroid. So, but generally, the patient goes back to normal after a few months. Treatment for exogenous thyroid hormone, they're present in some diet pills. Sometimes they're pharmacologically intentional to make the patient's TSH go down because the patient has papillary or follicular cancer because papillary cancer are TSH dependent, so we intentionally want the TSH to be on the low side, so we give the patient more than usual thyroid hormone. So it could be intentional. And the thyroid function test, since exogenous thyroid hormone, the T4 tablet that we talk about, are measured as T4, the thyroid function test is similar to primary thyroid toxicosis, whereby TSH will be suppressed. We don't do radioactive iodine because by history we already know the cause of thyroid toxicosis, but theoretically, if the thyroid gland is sleeping, the radioactive iodine should be low. But we don't have to do it because we already have a diagnosis. Thyroid hormone deficiency, very quickly, it could be due to secondary causes in the hypothalamus or the pituitary. If you don't have TSH to stimulate your thyroid gland, you'll have secondary hypothyroidism. But those are rare. Pituitary problems causing hypothyroidism are quite rare. The more common ones are primary, meaning the thyroid gland is the one that's defective. Okay. Manifestations depends on at what age. If it's congenital, then untreated, then you'll have cretinism, where the baby will be short and failure to thrive and have mental retardation. Nowadays, they say politically incorrect to call a person cretinism. We just say congenital hypothyroidism. And for adult, then there's going to be fatigue, decreased metabolic rate, so therefore they gain weight, they're cold. Rather than hyperreflexic, they're hyporeflexic manifestation. And also menstrual irregularity will happen, infertility will happen, and constipation. Almost everything's the opposite, bradycardia, the opposite of thyroid toxicosis. The treatment is to give levothyroxine, so this is T4. Goiter simply means enlargement of the thyroid gland. Most of these patients, in fact, are euthyroid, but patient can be hyperthyroid, like in Graves' disease. There's stimulation of every thyroid follicular cell, so you have a diffuse goiter. Or the patient can be hypothyroid if you have iodine deficiency. Goiter can happen because TSH will go up due to loss of negative feedback. If you have increase in TSH in hypothyroidism, goiter can happen also. But great majority of these patients with goiter are euthyroid. It's endemic if more than 10% of the population has it, and there's a, just like any thyroid disease, there's a female predominance. Generally, goiter the treatment is directed towards the cause if identified. Exogenous thyroid hormone, sometimes we give it. Even in euthyroid patients, the idea is to lower the TSH in an attempt to prevent TSH from stimulating the thyroid gland. So it does happen sometimes that the goiter will shrink with giving some amount of thyroid hormone. How about lumps and bumps? It could be cystic complex, which is a combination of solid and liquid in the same nodule, or purely solid. And if it's solid, generally we are concerned is there a chance of malignancy. But this is a general rule. Great majority of thyroid nodules are benign. Whatever the characteristic might be, it might be a male, a solitary nodule, cold nodule, whatever it is, majority of thyroid nodules are benign. Okay, only few percentage of thyroid nodules are malignant, and we already said majority of these patients are going to be euthyroid. So, what makes you suspect a particular nodule might be malignant? Clinical history. Rapidly growing makes it a bit more suspicious. Presence of significant cervical lymphadenopathy makes it suspicious. Family history of medullary thyroid cancer. History of irradiation to the head and neck area. All put the patient at risk. But it doesn't mean they have it. It just says that your threshold to go after it is going to be lower because of these particular features. And on ultrasound, there are certain features that we look for that also lower our threshold that we will go after a thyroid nodule. Okay, we don't biopsy all the nodules just because majority of thyroid nodules are going to be benign, but there are certain characteristics of a thyroid nodule that will tell us that need to be to do a fine needle aspiration biopsy. And these are hypoechoic if they have microcalcifications, because calcifications may represent samoma bodies of papillary cancer. Obviously, if they have irregular borders and they are microlobulated, solid compared to cystic, and if it's taller than wide. okay, on the transverse view. These are all suspicious, but not conclusive that they are malignant. These are just features that say, well, there's an increased tendency that it might be malignant. These are just risk, better biopsy. But in the absence of any of those that we mentioned, and they're small, generally we just leave it alone and observe them. So once you've decided to that the nodule requires a biopsy, then generally we just do a fine needle aspiration biopsy. And thyroid scan is not routine. I already said great majority of thyroid nodules are going to be cold anyway, okay? And the only time we do thyroid scan by recommendation if your TSH is low, okay? So every single patient with thyroid nodules should get a TSH because that's the best screening test. And if they have a low TSH, that signifies excess thyroid hormone. Therefore, there's a chance that the thyroid nodule is an autonomous nodule. And autonomous nodule, the chance of cancer is very small. So if the TSH is low and you're thinking there's a chance there's an autonomous nodule and the radioactive iodine scan indeed show that it's a hot nodule, then you don't have to biopsy it. The chance of that being cancer is less than 1%. So radioactive iodine is not routine. Most common cause of thyroid cancer is the well-differentiated. Papillary is still the most common one, and you have your follicular thyroid cancer also. These are generally well-differentiated, meaning they are cancer of the thyroid follicular cells. Anaplastic is less common. Lymphoma, medullary cancer is less common, and some cancer like breast can metastasize to the thyroid once in a while. Let's talk about papillary. Most common, just remember lymphatic. Okay, so generally they go to the lymph node versus follicular. Hematogenous, they have a higher chance of going to the lungs, the bones, as their site of metastasis. Both of which are good prognosis, but papillary is much better than follicular thyroid cancer. Staging is based on TNM. Generally, it's surgical, depending on the number of nodules and stage. We can either do a lobectomy or total thyroidectomy. And generally, follow-up is based on neck ultrasound, doing radioactive iodine whole body scan, or thyroglobulin levels. Okay. Many of these patients with well-differentiated thyroid cancer we'll just tell the patient, no matter how good your surgeon might be, there are micro metastases that they could have left behind. So in certain cases where the stage is a bit higher, we give them radioactive iodine at high doses to melt down whatever's left by the surgeon. And after which, since these are thyroid follicular cells and they are TSH dependent, rather than just giving regular doses of thyroid hormone, we just intentionally give them a higher dose, so that there'll be more negative feedback to the pituitary, because to keep the TSH low, because this papillary cancer and follicular cancer are TSH dependent. For the others, anaplastic lymphoma, medullary cancer, we do not give them radioactive iodine. They are not thyroid follicular cells, so they will not take up radioactive iodine, and neither do we do TSH suppression because they are not thyroid follicular cells. So they'll just do their own thing. They're not TSH dependent. So anaplastic, extremely poor prognosis. Lymphoma typically classically presents with rapid growth, but biopsy will say that they are not papillary cancer or thyroid cell cancers. So generally we don't operate on them. They respond well to chemotherapy and radiation. Medullary cancer is cancer of the parafollicular cells characterized by high levels of calcitonin. We just have to look at whether they are part of multiple endocrine neoplasia 2A and 2B. Read what multiple endocrine neoplasia 1 versus 2A and 2B, what they are. Generally, men 1 are the 3 cancers of the 3P endocrine. It's a cancer constellation of cancer of the pituitary, the parathyroid, and the pancreas is what men 1 is. Let's read through what men 2A and men 2B are. So what are the other pearls? We said that TSH is the first to become abnormal. So if you have still normal T4 and T3 with suppressed TSH, that means your pituitary is sensing some excess. We call this subclinical hyperthyroidism. There's still clinical significance, especially in older people. They're at higher risk for atrial fibrillation and osteoporosis. If the only one that becomes abnormal is TSH, meaning elevated, on the other hand, that means your pituitary is sensing some deficiency of thyroid hormone. This is what we call subclinical hypothyroidism. In elderly patients with hyperthyroidism, sometimes instead of being uh, agitated or irritable, they become sluggish or they're depressed. This is what we call apathetic hyperthyroidism, typically found in thyrotoxic patients who are elderly. And just remember, at the end of the first trimester of pregnancy, beta HCG goes up, it peaks, so mild goiter and mild thyrotoxicosis might happen temporarily. Then beta HCG will eventually go down during second and third trimester, therefore the goiter will shrink, and that thyrotoxicosis or hyperthyroidism is temporary. Don't have to treat that. In ICU particularly, there's a thing called sick thyroid syndrome, whereby thyroid hormone goes down. And this physiologic, you're not supposed to treat it. The modern name is called non-thyroidal illness, but typically patients are in the ICU. So the one that goes down first is T3. Okay, so low T3 syndrome is the most common type of sick thyroid syndrome. Let's go and talk about the adrenals. Okay, and this in anatomy or histology particularly told you how to remember the three different the two layers, general layers of the adrenal cortex and the medulla. Under the adrenal cortex, you have GFR. Memorize it a bit, not necessarily endocrinology. Will come out. It will come out in other subjects. G is glomerulosa, produces the mineralocorticoid aldosterone. The F is for cortisol. Reticularis is for small amount of androgens, important for um, in utero, fetal organ development. This small amount of androgen is important. So we'll talk about that when we go to CAH. Function of the renal cortex, regulation of blood pressure by the mineralocorticoid, particularly, and also regulates sodium and potassium. Cortisol is important for metabolism and immune system, and androgens from the adrenals are important for secondary sexual characteristics. So what can go wrong? Too much, too little. Okay, so of all the hormones, too much of those hormones can manifest as aldosteronism, Cushing's, hyperandrogenic state. It's a male. It doesn't matter because testicles produce even more androgens. But if a female adrenal release a lot of androgen, there might be some form of virilization and pheochromocytoma, excess of the catecholamines from the adrenal medulla. How about too little? So you have hypoaldosteronism, adrenal insufficiency, um, no hypoandrogenic state, except if it happens very early, okay, in utero, for example. And there's no hypoadrenalism because for catecholamines there are different sources. You have your sympathetic chain that also produce adrenaline. Okay, so there's pheochromocytoma excess, but there's no deficiency of catecholamines. And if you have tumor, it could be benign or malignant. So let's talk about the aldosterone first. Aldosterone is regulated by the renin-angiotensin aldosterone system. So generally, an example is if you have low blood pressure or low sodium, renin will be activated. Okay, if you have blood pressure, you want to activate the renin-angiotensin aldosterone system because the whole system will activate. Angiotensin 2 is one of the most potent vasoconstrictor, um, and so therefore blood pressure will go up. Okay, and angiotensin 2 will um, then activate the adrenal cortex to produce aldosterone. And the aldosterone, we know the normal function is sodium reabsorption, potassium excretion. So by increasing sodium, salt and water will be retained. You have more salt and water in your system, blood pressure goes up also. But to a certain extent, there's going to be a negative feedback. Once blood pressure is okay, or the amount of sodium is okay, the the renin will go down, so to prevent further stimulation of the whole system. So this the renin angiotensin aldosterone system. So what can go wrong if you have too much? Okay, hypertension will happen, and there could be hypokalemia if too much aldosterone. So there are aldosterone producing adenomas or hyperplasia, but we'll talk about the difference between primary and secondary hyperaldosteronism. So signs and symptoms could be weakness or fatigue due to hypokalemia, headaches due to hypertension, predominantly diastolic hypertension. Hypokalemia can produce nephrogenic DI that we talk about, meaning the distal tubule are resistant to antidiuretic hormones, so you're going to have polyuria and polydipsia. Chronic hypertension, if poorly controlled, can cause the left ventricular hypertrophy. And low potassium is associated with prominent U wave. And if it happens long enough, then the kidneys get damaged, then you have proteinuria and sometimes renal failure. So this is how it works. If you suspect somebody with poorly controlled hypertension and also low potassium, then you're going to suspect that they may have mineralocorticoid excess. So the screening test is aldosterone plasma renin activity ratio. And I don't think they'll ask this too much for you, but just know that the screening test, if you're suspecting, is a high plasma aldosterone over plasma renin activity ratio. So a high ratio makes you think that there's primary aldosteronism, meaning the renin is responding properly by negative feedback. So what's really wrong is an aldosterone producing cell. That's why it's primary. And typically aldosterone level is elevated above 15. Okay, then if you have this, then one can proceed to do a CT scan. But generally, we do some confirmatory biochemical tests. So primary aldosteronism, meaning there's autonomous production of aldosterone. Okay, so two causes. If they're going to ask something about this, is to differentiate. If it's adrenal adenoma, the treatment is surgery. Hyperplasia do not respond to surgery, so the treatment is an mineralocorticoid antagonist like spironolactone. Okay, for hyperplasia, we don't operate on them; they will not get better. Okay, only adrenal adenoma overproducing aldosterone will respond to surgery. If you have high aldosterone but your plasma renin activity is high, then that's something wrong with the regulation higher up. It's supposed to go down. Then you suspect the possibility of renal artery stenosis. You do a CT scan or some duplex studies of the renal artery. If there's a kind of a stenosis there, sometimes an angioplasty will be done. Or if you see a tumor there, then it might be a renin producing tumor. Okay, so to interpret this, generally we do a combination of aldosterone and renin. Okay, so if the renin goes down appropriately, then the problem is aldosterone producing cells. Okay, how about low aldosterone? It can be part and parcel of primary adrenal insufficiency. We'll talk about primary adrenal insufficiency later. So in primary adrenal insufficiency, all the layers of adrenal cortex are affected. So therefore, low aldosterone is part and parcel of that. In the past, the most common cause of primary adrenal insufficiency is tuberculosis. Nowadays, it's autoimmune destruction of the adrenal cortex. Treatment for low aldosterone is a mineralocorticoid, fludrocortisone. You don't hear this too much. This is a mineralocorticoid hormone, pure. It doesn't have glucocorticoid effects, not unlike dexamethasone or hydrocortisone or prednisone. This is a pure mineralocorticoid hormone. So adrenal cortex, primarily for cortisol production, many function. It's a stress hormone, but metabolically it has other function. It can increase plasma glucose by increasing gluconeogenesis. Just like what I said, it's one of the counter-regulatory hormones to insulin. So cortisol goes up every night when we're not eating because its function is to increase gluconeogenesis. So one can imagine in excess, diabetes can happen. Okay, but it has other metabolic function, just like protein catabolism. So therefore, you have too much cortisol, there's going to be muscle wasting and So it has anti-inflammatory effects, as you know, in many autoimmune diseases or rheumatologic diseases. They'll use this. Okay. It has antipyretic action, so we don't use it for fever, but if the patient on steroid, it can mask an infection. For example, the patient will not mount a fever. Um, it inhibits production of T cell growth, so very important for it can be used as an immunosuppressant for renal transplant, for example. So this is how it's regulated. What do we mean when we say Cushing syndrome? Syndrome generally is a constellation of signs and symptoms pertaining to a particular problem. Um, for example, congestive heart failure is a syndrome. It's due to something else. And Cushing syndrome is a syndrome of excess cortisol, and you have to investigate what's causing the excess cortisol. And I said this earlier, the most common, overall common cause of Cushing syndrome, okay, is exogenous intake. Patients who have really bad asthma, for example, COPD patients, patients on with lupus on steroids can become Cushionoid. That's the most common cause. Okay. If you're asked about what's the most common endogenous cause, the answer is an ACTH producing pituitary adenoma, or the other term for this is Cushing's disease. Okay. The other less common causes of endogenous are cortisol producing adrenal adenoma or hypoplasia, and even rarer are the cancers, the small cell, oat cell that produce ACTH, ectopic ACTH, or some pancreatic cancer can cause ectopic ACTH and cause Cushing syndrome that way. Okay, so Cushing syndrome, there's increased lipolysis in the subcutaneous tissues, but it transfers all the fat to the central part of the body. That's why there's central obesity in Cushing syndrome. We already said that it's one of the counter-regulatory hormones, so hyperglycemia or diabetes can happen. Say an example. The reason there's striae, white purpley striae, because of it has some mild proteolytic action in excess. That's exaggerated. The skin thins out, so the blood vessel thins out. That's why there's easy bruisability and also white purpley striae. Hirsutism can be found in female patients. Hypertension, we already said that it can cross, overwhelm the enzyme that breaks it down in the renal tubules, and then they start to exert mineralocorticoid effect, causing sodium reabsorption and potassium excretion. So hypokalemia and hypertension can happen. Gonadal dysfunction, there's a cross negative feedback to LH-FSH by cortisol, and psychological, you've heard of steroid psychosis, right? So sometimes there could be psychological disturbances. Muscle weakness, two reasons, partly hypokalemia and partly because of protein lysis of the muscles. Osteoporosis due to calcium osteoclast activation, and because of hypercalciuria, there's increased risk for kidney stone. So these are the clinical manifestations, but yeah, some of them have high glucose level, and we know that they excrete more calcium in their kidneys. So first thing that you evaluate patient with Cushing syndrome is ask them about their medication. If the medication includes a steroid, then you have your answer. That's the treatment is to taper it down. Okay, never suddenly withdraw or stop somebody who's Cushionoid due to exogenous steroids, because the whole system is shut down. Remember, it's an essential stress hormone. You can precipitate an adrenal crisis, and patient can die if you suddenly stop somebody who's Cushioned for exogenous Cushing. So the key word there is taper, not stop suddenly. Okay. So if it's exogenous, no other test is needed. You're done. Okay. Treat. How about endogenous? If after taking a good history, there's no exogenous intake of steroids, and you suspect the patient to have hypercortisolism, there are three tests that you can request for. 1 milligram overnight dexamethasone suppression test. Remember, we said if you have suspecting excess, you suppress. So by giving dexamethasone, it's supposed to have a negative feedback on the CRH and ACTH. So the following morning, cortisol is supposed to go down if you're normal. If it did not, then you have endogenous excess of that hormone. You can measure 24-hour urine-free cortisol and also measure salivary cortisol at its nadir. So once you have endogenous, those three screening tests are abnormal, then you differentiate whether it's ACTH dependent or ACTH independent so that you know which radiologic test you're going to request for. If it's ACTH, if it's high, then the first thing that you go is MRI. Remember, Cushing's disease still outnumber ectopic ACTH. If the ACTH is low, that means the pituitary is responding appropriately, then the problem must be at the level of the adrenals. Treatment for Cushing's disease, transphenoidal surgery. For ACTH producing tumor, you remove or do chemotherapy of the lung cancer if it's a lung cancer. If the cortisol producing adenoma, then you have to operate on the adenoma. Okay? But since the other side of the adrenals are sleeping due to excess cortisol, it will take time for that to wake up, just like if you're taking too much thyroid hormone. So one can expect adrenal insufficiency after a removal of a cortisol-producing adrenal adenoma. Deficiency, okay, again, a common ask question. Okay, these are manifestations, the opposite. The patient can be hypotensive, hypoglycemic. Um, there's primary, meaning there's the problem of the adrenal itself. The most common cause is autoimmune nowadays. TB is less common worldwide. And you have secondary, which means the problem is at the level of pituitary. One example is Sheehan syndrome. Okay. Um, so how do you differentiate? The cortisol is low, then ACTH is high. That means there's nothing wrong with the pituitary. Then you call this a primary adrenal insufficiency. If somebody with low cortisol, the ACTH is low, then you suspect the problem is at the level of the pituitary. Okay. So again, to differentiate the two primary, there's hyperpigmentation because um, CRH is also the precursor for MSH, melanocyte stimulating hormone. So MSH goes up. That's why in primary AI there's hyperpigmentation. Okay. And in primary AI, since all layers are destroyed, there's mineralocorticoid deficiency. Okay. In secondary, since the glomerulus layer is not regulated by the ACTH, your renin-angiotensin-aldosterone system is intact. And since ACTH is low, the problem's upstairs, so therefore there's no hyperpigmentation. Remember, this is a common question on board exam. Uh, so we already said most common causes primary AI. Okay, there are less common causes. HIV can be one of them. Laboratory findings because of adrenal insufficiency. You'll have low cortisol, low sodium, and high potassium, just the exact opposite of hypercortisolism. Okay, so we can do a morning 8 a.m. cortisol because that's the peak of cortisol in the morning. But you can also do an insulin tolerance test, just like discussed earlier. Okay, so it is the gold standard. Okay, it's supposed to stimulate the whole system. Since hypoglycemia is stressed, it will activate the whole system. And at the end, you measure the cortisol. If it did not go up, there's something wrong with somewhere. It could be the pituitary, it could be the adrenals. You don't know yet. You need to measure ACTH to differentiate which level is defective. Okay, so one can do a ACTH stimulation test or an artificial ACTH called cosintropine to see whether the adrenal glands will respond appropriately or not. Treatment is to give glucocorticoid. If it's a primary adrenal insufficiency, the aldosterone layer is affected, so you have to give fludrocortisone in some patients with primary adrenal insufficiency. In its extreme form, we call this adrenal crisis. It's an emergency. Patient can die from it. Okay, and they typically present with either fever, intractable nausea, vomiting, and abdominal pain. And there could be hypotension also. If it's adrenal crisis, then you have to give the steroids intravenously. Uh, Excess of adrenal androgens depends. If it's a male patient, you won't even know it because, like I said, the testicles produce more androgens. If it's a female, there could be hirsutism and virilization. Let's talk about congenital adrenal hyperplasia. This probably will be discussed in pediatrics, but because 21 hydroxylase, among these, 21 hydroxylase deficiency is the most common one. That's why it's part of the congenital screen. Okay, so there are three parts of in congenital screen. There are three that they test. It's to test for 21 hydroxylase deficiency, for hypothyroidism, and also for glucose 6 phosphate deficiency. Okay, those are the three. So let's talk about these three. Okay, and try to understand. You don't have to memorize. I don't think they'll go deep into this, but let's try to understand these three different CAH. So 21 alpha hydroxylase deficiency comes in two forms: the classic form and the non-classic form, meaning this is fully penetrated, all cells affected. This is only mild 21 hydroxylase deficiency, so manifestation is not as bad. So in its pure form, there could be hyponatremia, hyperkalemia, hypotension, ambiguous genitalia only affecting females but not males, okay? And this very elevated 17 hydroxyprogesterone. So remember, 17 hydroxyprogesterone for screening for 21 hydroxylase deficiency. For all the others, they tend to manifest later in life, okay? And typically teenage, and when they present with some hirsutism and um, sometimes increase size of the clitoris, for example. So let's understand 25 alpha hydroxylase deficiency. These are the three layers: glomerulosa on the left, followed by fasciculata, middle column. Third column is reticularis for adrenal androgens. So 21 hydroxylase is important for metabolizing progesterone downwards to aldosterone, and for 17 hydroxyprogesterone downwards to cortisol. So if you have deficiency of this enzyme, everything will be directed to the right side. Okay, in which case you'll have low aldosterone and low cortisol, causing hypotension, hyponatremia, okay, salt losing, and then there's going to be a lot of adrenal androgens. So in utero, if you have a lot of adrenal androgens, if it's a male baby, it won't be affected. But if you have a female baby and you have a lot of adrenal androgens, there could be ambiguous genitalia. Okay, so that explains it. 11 beta, okay, they have hypertension, okay, and 70 also have hypertension. In 11 beta, so remember the ones, the 21 and the 11, the one that ends with 1. Female could be affected in terms of their genitalia, and I'll show you why 11. There's also virilization, okay, but not males. Again, males, we need the androgens for um, for the formation of genitalia in utero. But this one has hypertension. Okay, why? Let's look at what it does. Okay, so 11 beta hydroxylase is lower down after 21 hydroxylase. Okay, so if you block this two, aldosterone won't be formed, cortisol won't be formed either. Okay, and everything will be directed to the right side again, forming a lot of adrenal androgens. Therefore, there might be a female ambiguous genitalia. But instead of hypotension, hypertension happens with 11. Why? Because 11-deoxycorticosterone and 11-deoxycortisol have some mirocorticoid and glucocorticoid effects. So therefore, the manifestations of low aldosterone and low cortisol does not happen with 11 hydroxylase deficiency. In fact, 11-deoxycorticosterone is a very potent mineralocorticoid. Therefore, that's why hypertension and hypokalemia happens because of accumulation of 11-deoxycorticosterone. Let's go to 17, even rarer, okay? It also causes hypertension and hypokalemia, just like 17, okay? So you have two CAH that causes hypertension. It's 11 and 17, okay? And 21 is hypotension. This is the opposite, okay? What happens is if 21 and 11 affects female fetus, in 17, what's affected is a male fetus. You'll have ambiguous genitalia in the male, okay? Let's explain. 17-hydroxylase is important for converting the column, the precursors in the left column that goes to aldosterone to the right side. If you block this because you have deficiency, everything will go down to aldosterone, explaining the hypertension and hypokalemia. In utero, you are dependent on adrenal androgens to form male genitalia. You block this, nothing goes to the right side, okay? If it's a female, they don't need it, so it doesn't matter. They won't be affected. But if you're a male and you lack adrenal androgen, then they may have ambiguous genitalia. In fact, they may have present with a female genitalia. Let's talk about pheochromocytoma quickly. So this is adrenal medulla layer. So we know it's catecholamines. These are a normal function, okay, basal metabolic rate, and maintain bronchodilation and heart rate. Okay, so it has some increased lipolysis and it promotes gluconeogenesis. Again, one of the counter-regulatory hormone. In fact, is the reason why you're sweaty and you're having palpitations and tremors if you're hypoglycemic. Is a hormone that's triggered. It's one of the counter-regulatory hormones. Okay. So in excess, you have pheochromocytoma. So if it's outside the adrenal medulla, meaning your excess of catecholamines is in the sympathetic chain, then the name is called paraganglioma. So they kind of go together. Pheochromocytoma if it's the adrenal medulla excess, paraganglioma if it's sympathetic chain excess. Deficiency, we already said, it does not happen. Okay, even if you remove the adrenal medulla, the sympathetic chain will produce catecholamines. A certain rule of 10, okay? 10 are extra adrenal, just like what we said, paragangliomas. 10 could be multiple, bilateral, familial, or malignant, which means majority of pheochromocytomas are benign, majority are single, majority are unilateral, and majority are not familial disease. These are just sporadic diseases. Okay, could be could be part of MEN2A and MEN2B, okay, and this is associated with a Brett proto-oncogene abnormality. It could be part of von Hippel-Landau, okay, so there could be hearing problem that goes with it, okay. Screening is a 24-hour urine metanephrines. What we can do plasma metanephrine also. And if confirmed, you can do CT scan or MRI. So we already said extraadrenal pheo is called paraganglioma. Okay. Treatment is to alpha block them. Okay, especially if you're going to operate on them, the preparation is to give alpha blocker. The most effective one is phenoxybenzamine, not available in the Philippines, but we can give other alpha blockers used by urologists to relax the internal sphincter, like tamsulosin, alfulosin. Okay, so doxazosin. These are the alpha blockers, the antihypertensive, the alpha blockers should be used to reduce circulating catecholamines. But generally they have resistant hypertension, so therefore they will need other antihypertensive. The rule in red is never start a patient whom you think may be having pheochromocytoma with a beta blocker as their first line agent. It could be a second line agent after alpha blocker, but if you give beta blocker to somebody with pheo, you can precipitate a hypertensive crisis, and another potential question for the board exam. So let's go to spend some more time in diabetes and a little bit of obesity and calcium. Okay. So let's go very fast here. Okay, I'll pause when it's important. These are basic that you need to know. Okay, alpha cells produce glucagon. It works opposite that of insulin. Okay, it promotes glucose to go up rather than go down. Insulin primarily it causes glucose to move intracellularly to be source of energy. However, it also lowers amino acid and free fatty acids. So that's why in patients with insulin deficiency, type 1, type 2, there's increased circulating free fatty acids. Diabetes in general is not just a disease of carbohydrate metabolism, it's also a disease of protein and carbohydrate metabolism. However, since sugar is the one that causes most of the harm and it's the one that's really measurable, then it looks upon as a disease of glucose, when in fact all three different metabolism are affected or may be affected. Insulin deficiency or insulin resistance leads to type 2. Lack of insulin leads to type 1. Both types will have hyperglycemia, increased free fatty acids, and increased amino acid. Because of osmotic diuresis, glucose is an osmotic agent. The patient may have polyuria and polydipsia. Okay. Weight loss, because the body cannot use glucose, it will start to use fats and protein as source of energy in certain situations. Let's talk about etiologic classification. Type 1, we know its majority is immune destruction, complete destruction of beta cells causing insulin lack. For type 2, it's insulin resistance and also relative insulin deficiency, but there's more. We'll talk about that later. Then you have the specific types. Stay focused on letter E particularly, okay? Endocrinopathies. Remember, there are 4 counter-regulatory hormones for insulin. Every time you are fasting, there are 4 hormones that goes up to raise your sugar. Glucagon, cortisol, growth hormone, and catecholamines. So it makes sense if you have any excess of these 4 in acromegaly, Cushing syndrome, glucagonoma, and pheochromocytoma. Part and parcel of the problem might be hyperglycemia or diabetes. And then you have your gestational diabetes. So diagnosis, there are 4, okay, just memorize them. But there's pre-diabetes. If it's fasting, we call it IFG. If it's after glucose tolerance test, we call it impaired glucose tolerance. Okay, so I'd like you to memorize 4 numbers, because once you hit or step on this number, you're at a different category. Fasting, if you step on 100, you have impaired fasting glucose, because impaired fasting glucose is 100 to 125. Once you step on 126, you have diabetes. For OGTT, if you step on 140, you have impaired glucose tolerance. If you step on 200, then you have diabetes. So remember, the number it will put you at a different category rather than memorizing the range. Type 1 is an autoimmune destruction. There are a few percentage whereby they have complete destruction, but they don't have autoimmune antibody. The one we measure is anti-glutamic acid decarboxylate and the anti-islet cell antibody. They're ketotic prone because of lack of insulin. Okay, typically there's a trigger, there's a genetic predisposition, and then there's going to be a trigger, either an infection virus or some food. Type 2 is a little bit more complicated. The simple way is insulin deficiency by the pancreatic cells, and then on the right lower is insulin resistance at the level of the liver, muscle, and adipose tissue. Therefore, sugar cannot go in properly. Okay. However, there are other problems. Look at number 2 below number 1. Incretin effects. What are incretins? Incretins are example is GLP-1. These are hormones produced by the gut to help the pancreas release the right amount of insulin. So this is also defective in patients with type 2 diabetes. That's why later on when we go to medication, one of the treatment is to inject GLP-1 receptor agonist. Okay? And we also know that incretins GLP-1 is broken down by DPP-4. So we'll talk about DPP-4 inhibitor. If you inhibit the enzyme that breaks down your beneficial GLP, your own endogenous GLP-1 receptor agonist, GLP-1 will last a little bit longer. So it will help and hang around to promote and help the pancreas produce some insulin. Okay? So that's defective in patients with type 2 diabetes. And defect number 3, in type 2 diabetes, there's excess of glucagon. So that explains why there's fasting hyperglycemia. How come the patients who are sleeping and type 2 diabetes, they wake up with high sugar? Because their alpha cells is exaggerated in terms of producing glucagon. Down the line, in the middle, all the way down, there's also a problem of increased glucose reabsorption. We know very well that the renal threshold for glucose reabsorption in the kidneys is about 160 to 180, beyond which you will start to have glucosuria. That's for normal people. In patients with type 2 diabetes, for some genetic defects, they won't spill glucose into the urine not until they reach about 220. So therefore, further contributing to hyperglycemia. That's why there are what we call SGLT2 inhibitors. SGLT2 is the receptor within the renal tubules where glucose reabsorption happens. So if you inhibit this, then glucose will not be reabsorbed. So SGLT2 inhibitors promotes glucosuria, and that's how it lowers glucose. So we'll talk about that when we go to medications. Why do we care about diabetes? Because they're at higher risk for macro and microvascular complications. And it's known that if you have better glycemic control, there's reduction in microvascular complications of retinopathy, okay, diabetic kidney disease, and neuropathy. So management goal generally is to eliminate symptoms. We don't want the patient to be waking up the whole day, the whole night rather, because of polyuria and nocturia. We don't want them to be thirsty all the time, so eliminate some of the symptoms. We want to reduce micro and macrovascular complications of type 2 diabetes. So let's talk about medications for type 2. Okay, for these, generally you have to memorize 2: the mechanism of action and the side effects. Okay, for metformin, the most common side effect is gastrointestinal upset. The most dreaded side effect is lactic acidosis, rare but potentially fatal. It's been known also for several years that if you're on metformin at high doses, there might be B12 deficiency. So if it's a matching type of question, which one can cause B12 deficiency, it's metformin. For sulfonylureas, it's well known that they can cause hypoglycemia and weight gain because they promote insulin secretion. Insulin is an anabolic agent, so therefore it can promote weight gain. So it works by helping the pancreas produce insulin. TZDs is an insulin sensitizer. So, however, it causes weight gain. There could be fluid retention, contraindicated in patients with heart failure, and associated with osteoporosis. Alpha glucosidase inhibitor. Why do you want to inhibit it? Alpha glucosidase is an enzyme that breaks down starch in your intestine to simple sugar. So you need sugar to be in its simple form for absorption. So what alpha glucosidase inhibitor would do is prevent or making starch stay as starch, so that postprandially the glucose does not go up. However, because of starch going to the colon, there is a fermentation that happens, so therefore flatulence is common among patients with alpha glucosidase inhibitor. DPP-4 inhibitor, we talk about this briefly. It's an enzyme, DPP-4 is an enzyme that breaks down your incretin, the beneficial GLP-1. So by inhibiting this enzyme, the beneficial GLP-1 will last a little bit longer in your system and help promote insulin secretion and suppress glucagon production. SGLT2 inhibitor lowers the threshold, okay, for this drug. You start to spill glucose in the urine at around 80, so therefore that helps promote glucosuria and reduce hyperglycemia. The only thing though is with high glucose in your urine, the bacteria loves it, higher chance of genitourinary infection. Okay. What's really nice about SGLT2 inhibitor, they have been found over the past 3 years to be cardioprotective. Next is GLP-1 receptor agonist. So there's a deficiency of GLP-1, the incretin, right, in type 2 diabetes. So rather than just relying your endogenous GLP-1 and using DPP-4 inhibitor, you can actually inject a pharmacologic dose of GLP-1, what we call GLP-1 receptor agonist. They also has been known to have some cardiac protection. So these two drugs, among all the drugs, have some cardioprotective effects. What's really nice about these two drugs also, they promote weight loss rather than weight gain. Okay. Then you have your insulin. Of course, insulin deficiency makes sense to inject insulin. However, side effect is weight gain and hypoglycemia. As much as we want to lower the glucose of patients with diabetes, there are certain concerns that we look for in characteristic of a drug. Hypoglycemia, we're afraid of hypoglycemia. Generally, most of the drugs are low risk for hypoglycemia except sulfonylureas and insulin. In terms of weight, we already said that metformin, GLP-1 receptor agonist, SGLT2 can have some weight loss. It's neutral with DPP-4 inhibitors and alpha-glucosidase inhibitor, but with TZDs and sulfonylurea, you will have weight gain. So if the patient is already heavy, then we generally, one of the things that we think about is to avoid TZDs and sulfonylurea. How about renal insufficiency? Okay, so there are certain contraindications. You don't need to know this, but generally, if you have low GFR, most of the drugs are contraindicated. Okay. GI side effects notoriously are the GLP-1 receptor agonist and metformin. Cardiac protection for GLP-1 receptor agonist and SGLT2, neutral for most, and increased heart failure for TZDs. Bone, increased fracture and osteoporosis for TZDs. And the one that can cause possible DKA among these oral drugs is SGLT2 inhibitor. This is the latest guideline. It used to be that when you choose medications, you look for side effects, okay, or you look for to avoid side effects. But nowadays, the guideline would say that after metformin, if the glucose is not well controlled, the next question to ask is whether the patient has atherosclerotic cardiovascular disease, congestive heart failure, or kidney disease. If they do have any one of these three, the next line medication is either a GLP-1 receptor agonist or an SGLT2 inhibitor. Then you have different types of insulin. You have your basal insulin and prandial insulin. Generally, the prandial insulins are the rapid ones to cover the food that you eat. Both for type 1 type 2, they can be on insulin. Then you have acute complications. Let's talk about DKN and HHS. Okay, so DKA, there's a precipitant cause. We know that type 1 is ketotic prone compared to type 2. There's increased lipolysis and fatty acids, and excess fatty acids is what form your keto acids. So glucose goes up, ketoacidosis happens, okay, and this is DKA. There's also excess glucagon. Generally presentation and could be nausea, vomiting, and abdominal pain. And some patients will have rapid deep breathing called Kussmaul's respiration, and they may have acetone breath. Treatment, once identified, is hydration, hydration, hydration. Just by expanding, because of osmotic diuresis, these patients are generally dehydrated. So by expanding their intravascular volume, blood pressure improves, um, glucose in the blood gets diluted, so glucose level goes down a little bit. Uh, Glomerular filtration rate improves, so there's some amount of increased spill of glucose into the urine, causing the glucose to go down. And of course, you have to give insulin therapy, typically insulin drip. Potassium generally is total body potassium is generally low. Bicarbonate is not given unless the pH is less than 6.9. HHS, more common in type 2. Generally, insulin deficiency is not enough to maintain normal blood glucose, but it's enough to prevent lipolysis. So ketoacidosis does not happen, or at least only mild ketoacidosis might happen. But because of generally they have very high levels of glucose, 500, 800. These patients are even much more dehydrated than DKA, and so they can be hypertensive. And so the treatment, still hydration, hydration, hydration. Sometimes you have to do CVP, central venous pressure guided hydration. Treatment is insulin drip, okay, and treat the underlying cause or precipitant cause. Chronic complications are the microvascular complications of retinopathy, neuropathy, and nephropathy. Okay, it takes time for this to happen, and there are a lot of hypotheses on why this happened. It could be non-enzymatic glycosylation of protein, or glucose converted to sorbitol by aldose reductase. Retinopathy, okay, hallmark of proliferative is neovascularization, improvement by better glycemic control. If the patient has proliferative retinopathy, they can undergo laser photocoagulation or injection with anti-VEGF. Diabetic kidney disease, KW lesions, know this. Kidneys generally do not shrink even in CKD. Earliest sign is microalbuminuria. Better glycemic control, blood pressure, and also low protein diet improves this condition. Preferred antihypertensive, ACE inhibitors, and ARB. Most common cause of neuropathy is distal symmetric peripheral neuropathy, manifested as numbness, tingling, and neuropathic pain, typically following a stocking and glove pattern. Okay, of course, because of numbness, high risk for amputation. Ordinary NSAIDs won't work. You have to give pregabalin or duloxetine. These are anti-epileptic and antidepressive drugs. And autonomic neuropathy can manifest as erectile dysfunction, gastroparesis, or orthostatic hypotension. The other group of chronic complications are the macrovascular, three of them: the carotid, the coronaries, and the peripheral arterial disease. That's why we ask about intermittent claudication among these patients. We ask about TIAs, we ask about angina. Okay. However, preventing macrovascular complications is less related to glucose control. And if they do have this, then I already said that drug of choice could be SGLT2 inhibitor or GLP-1 receptor agonist on top of metformin. Those two has extra macrovascular complication advantage or prevention. And these are the general targets. LDL, we want it below 100 for most. If they have high risk, we want it less than 70. We want their HDL above 40 in males, above 50 in females, and generally we like the triglyceride below 150. Blood pressure should be maintained less than 130/80. Target A1C is generally less than 7%. So we focus on management, which includes smoking cessation and in some patients antiplatelets. They're prone for more infection like UTI, cellulitis. In fact, pulmonary tuberculosis is more common in patients with type 2 diabetes. And this could be due to poor circulation or glycation of leukocyte, making them less effective. Gestational diabetes, if you're going to screen, it's at 24 to 28 weeks. Or if they're very high risk, it should be done at the first prenatal visit. We either do a 100 grams or 75 grams oral glucose tolerance test. Why do we care? If poorly managed, patients may have large babies, higher risk for stillbirth, higher risk for cesarean section, and higher risk for neonatal hypoglycemia. Managed well, they're as good as any non-diabetic pregnant mother. Insulin in excess can cause hypoglycemia. Okay, if it's endogenous, we call this insulinoma. Okay, the Whipple's trial is a documented hypoglycemia, meaning by finger stick or blood test, classic symptoms of palpitations and sweating, and release of those symptoms once the glucose level is corrected. It's called what we call Whipple's trial. Hypoglycemia can be a complication of treatment of diabetes. We talk about insulin and sulfonylurea is particularly notorious for those. All the others are not as bad. And there could be a defect in counter-regulatory hormones. So one can understand that in cortisol deficiency, adrenal insufficiency, they can manifest as hypoglycemia. Treatment depending on symptoms. If it's lethargic, then do not force oral glucose. They will aspirate. Just infuse. Put a line in. If they're awake, just give them simple sugars. Overweight, okay, just remember these numbers using BMI. Okay, for Caucasians, it's 25. Will put you at a different category. But since Asia Pacific, Asians are smaller frame, you start to become abnormal at 23. So just remember those two numbers generally. For waist circumference, where the central visceral obesity, the metabolically active fats are, the normal is should be less than 80 for women, less than 90 for men in Asia Pacific. Caucasians are 88 and 102. The pattern of obesity is bad if it's central, like apple shaped. It's not as bad if it's subcutaneous, like android shaped obesity. Talk about dyslipidemia quickly. Okay, we know fats are water insoluble, so to be carried in the circulation, they have to be attached to some water soluble apoproteins, and these are the different forms of apoproteins. The bad ones are the B100s. Okay, anytime a particular lipoprotein has B100, they are quite atherogenic. One by one. Okay, chylomicrons produced in the intestines, they are triglyceride rich. Okay, hydrolyzed by lipoprotein lipase to a triglyceride poor remnant, chylomicron remnant. This chylomicron remnant is cholesterol rich, so it's quite atherogenic. VLDL, on the other hand, is produced by the liver, also high in triglyceride, hydrolyzed by lipoprotein lipase and hepatic lipase to intermediate density lipoprotein, further metabolized to LDL, the worst of the in terms of atherogenesis. LDL, end product of VLDL, carries 70% plasma cholesterol. It's the main atherogenic cholesterol. HDL is the good cholesterol. It functions as a reverse cholesterol transport, and if it's very high, above 60, it's considered a negative risk factor for coronary heart disease. There are different types of dyslipidemia, okay, and this classification is 1. If you want to memorize, okay, on the opposite ends of 1 and 5, these are the ones that are rich in chylomicrons. So screening, we did a lipid profile, 10 to 14 hours of fasting. Okay, LDL generally is computed, but it can be directly measured in certain laboratories. So a lot of times LDL is just derived. It's subtracting HDL and 20% of the triglyceride from total cholesterol will give you an estimate of what LDL is. But once the triglyceride is above 400, this formula is no longer accurate. Secondary causes. Every time you have dyslipidemia, especially those who are already on treatment, one should, and the cholesterol still remains to be high, or they have unusually high levels of cholesterol, one should look for secondary cause of dyslipidemia like hypothyroidism, diabetes mellitus, and nephrotic syndrome. Treatment, rule out secondary causes. Okay, so diet therapy is part and parcel. Okay, in certain situations we try 6 months of diet therapy, but if it's extremely high, especially in patients who are diabetic and have previous cardiovascular disease, we don't wait around for 6 months for diet. We go directly to treatment. Okay, but at best diet will only lower your LDL by about 10%, not too much. The most popular drug to lower bad cholesterol are the statins. You have rosuvastatin, atorvastatin. This inhibits a rate-limiting enzyme in cholesterol synthesis. It upregulates number of LDL so that the LDL receptors will suck up more LDL into the liver and take them away from the blood. It can decrease the LDL by as much as 50%. And LFTs and muscle aches are quite rare, but we routinely ask about this in our patients. Fibric acid derivatives are primarily for, not for LDL lowering, they for triglyceride lowering and raising HDL. Side effects are GI cramps and cholelithitis. However, when used in combination with statin, they are at higher risk for liver function test abnormalities and might increase the risk for myalgia and myositis. But we combine them. Okay, so it's primarily for lowering triglyceride and raising HDL. Statins are not very strong for lowering triglyceride or raising HDL, but very good for lowering LDL. Bile acid sequestrants, they bind intestinal bile acid that causes increased conversion of cholesterol to bile acid, and then there's going to be upregulation of LDL. The This is used only for pure form of high LDL. If the patient has a combination of high LDL and triglyceride, you're not supposed to use this one because it generally will increase your triglyceride. Niacin, not very popular nowadays. It stimulates lipoprotein lipase. Okay, it's otherwise known as nicotinic acid or vitamin D3. It lowers triglyceride. It can also lower LDL minimally, increase HDL, causes increased glucose, and yeah, it's been known to promote diabetes, and that's why it's not being used anymore too much. It has GI side effects and hot flashes. I think this should be a topic in biochemistry still, the dyslipidemia, and cardiology might touch upon it a little bit. But let's go to the last part, the calcium as the parathyroid. Okay. When we talk about calcium and phosphorus metabolism, it's 3 and 3. You have 3 hormones and 3 effector tissues. Okay, you have your parathyroid hormone. Vitamin D is a hormone. Okay, and the calcitonin in small letters because we already said that it plays minimal role. Effector tissues are the kidneys, for which calcium is reabsorbed or excreted. Intestines, where calcium absorption. Bone, we talk about deposition of calcium, and bone resorption, release of calcium. Okay, these are the terminologies that helps in calcium and phosphorus metabolism. Let's talk about the most important one, parathyroid hormone from the parathyroid gland. We have 4 parathyroid glands. Some people will have 3 or 5, but all you need is one for the parathyroid hormone to work. Okay, so how does it affect the bones? It stimulates osteoclast, okay, that causes bone resorption, so net effect, calcium and phosphorus goes up when it comes to the bone. But the most potent effect of parathyroid is at the level of the kidneys. It causes calcium reabsorption and phosphorus excretion. It also activates the last step of vitamin D to the 1-alpha hydroxylation happens in the kidneys. Okay, and GI tract, there are no receptors for parathyroid hormone. However, the effect is indirect. By increasing 1-alpha hydroxylation, you're increasing the active, you're converting 25 hydroxy vitamin D to the more active 125 dihydroxyvitamin D, and it's this active vitamin D that has effects on the gut in terms of calcium and phosphorus absorption from food. So how is it regulated? Calcium and vitamin D exerts negative feedback or the active vitamin D. So there, within the receptors of your parathyroid gland, there are receptors for calcium and active vitamin D. So once the parathyroid gland knows that there are enough calcium or active vitamin D, it will not release a lot anymore. Okay, that's a normal function of the parathyroid. Deficiency of parathyroid hormone is called hypoparathyroidism. It can cause osteomyelitis and hypocalcemia. Excess causes hyperparathyroidism that leads to hypercalcemia and hypophosphaturia, some kidney stones, and osteoporosis. Next hormone, let's talk about vitamin D. We get it from diet or UVB from exposure to the sunlight. But once in the body, it has to undergo two hydroxylation steps to become active. The first one is in the liver, 25 hydroxylation, and this is the storage form. The storage form is what determines whether you have vitamin deficiency or not. Okay, so if you're gonna check for vitamin D deficiency, what you have to write for is 25 hydroxyvitamin D. Okay, and then it will eventually be activated to the active vitamin D by 1-alpha hydroxylation in the kidneys, which is also regulated by the parathyroid gland. So the final active product is a 125 dihydroxyvitamin D. So what are the effects of vitamin D? It's mainly in the gut. It helps absorb both calcium and phosphorus. In the kidneys, it also increases reabsorption of calcium and phosphorus. So the net effects of vitamin D is to increase both calcium and phosphorus. So it interplays, coexists with parathyroid hormone, okay, to regulate calcium and phosphorus. So how is vitamin D regulated? How do we know when to activate vitamin D? So one pathway, number one, is once calcium goes down, parathyroid hormone, by loss of negative feedback, will be activated. Your circulating PTH goes up. There's going to be increased 1-alpha hydroxylation in the kidneys, activating your vitamin D. So that's one regulation. But once the calcium or phosphorus goes up, that can directly suppress 1-alpha hydroxylation in the kidneys. The active vitamin D itself suppresses further 1-alpha hydroxylation. So vitamin D deficiency leads to hypocalcemia and hypophosphatemia. That leads to defective mineralization of the bone. In children, you call it rickets. In adults, it's osteomyelitis. They commonly, both in adult and kidneys, in kids and adults, are manifested as bowing of the legs. The third, least important, okay, are from the parafollicular cells. We said generally they work opposite of parathyroid hormone in the petri dish, in vitro. But in vivo, they have negligible role. We already said that even if it's high in medullary thyroid cancer, or if it's low because you remove all the parafollicular cells during total thyroidectomy, as long as the parathyroid gland is there, calcium will remain to be normal. So it's really negligible. The main role of calcitonin is it works as a marker for diagnosis and also as a marker for recurrence of medullary thyroid cancer. Cause of hypercalcemia could be parathyroid related or non-parathyroid related. Okay, so it could be malignancy, hypervitamin D, or too much calcium ingestion. Okay, so just to delineate, the first thing that you have if you diagnose somebody with hypercalcemia, you have to do a paired test with PTH. If the PTH is appropriately low in somebody who's hypercalcemic, then your parathyroid gland is working fine. The problem is somewhere else. It's either you have cancer somewhere, or you have taken too much vitamin D, or just taking too much calcium. However, if your calcium is elevated, generally by negative feedback, PTH should be low. If it's normal or high, then you have primary or tertiary hyperparathyroidism. We'll talk about terminologies in a while. Most common cause of primary hyperparathyroidism is a single adenoma. Treatment, parathyroid surgery. Okay, so let's talk about hyperparathyroidism. It just means high PTH. It comes in three different forms: primary, secondary, and tertiary. Let's define them. Primary, we already defined. These are uh, patients with high calcium yet high PTH, and there's an intrinsic problem with the parathyroid gland. Okay, there's either an adenoma being most common. Secondary hyperparathyroidism is an elevation of PTH due to hypocalcemia, typically found in patients with advanced kidney disease. Okay, so it's because of lack of vitamin D, activation of vitamin D in patients with advanced kidney disease, there's going to be hypocalcemia. By compensation, PTH will go up. So this is kind of a physiologic if we talk about secondary hyperparathyroidism. Tertiary hyperparathyroidism is an autonomous PTH adenoma or hyperplasia that comes from secondary because of constant stimulation due to low calcium. PTH constantly stimulated. Um, with time, they become autonomous. And then this is what we call tertiary. Okay? So in primary hyperpara, calcium is elevated, okay, because there's a problem with the parathyroid. Same thing with tertiary. In secondary, the PTH went up due to low calcium. So hypocalcemia, these are the manifestations: numbness, paresthesias, in severe form tetany. There could be prolonged QT, interval. You can elicit it by Schwarz-Steckstein or Trousseau. And this is the normal physiology or regulation of calcium. Okay, this is PTH in the y-axis and then calcium in the x-axis. Normally, okay, this is normal in white box. As calcium level goes up from right to left, PTH will be suppressed normally to lower level. Okay? So look at the blue and the red. If you have hypercalcemia and the normal is by negative feedback, PTH is supposed to go down in red, then you have hypercalcemia from other causes. This is not hyperparathyroidism. In blue, you have hypercalcemia and PTH is elevated, meaning PTH is the cause of the hypercalcemia. So you have primary hyperparathyroidism. Let's look at hypocalcemia to the left. Normally, if you're hypocalcemic, PTH is supposed to go up. Okay? If it's down, then you have hypoparathyroidism. Osteoporosis is thinning of the bone, decrease in bone strength, which is a combination of bone density and bone quality. This architecture, okay? Bone density is the amount of calcium and mineralization. Bone quality is architecture. It's like the Eiffel Tower, okay? You have your steel, but the amount of steel does not solely um, determine the strength of the Eiffel Tower. The architecture, how the bracing will go from left to right and how many of them will be needed, is the architecture that will give you the strength also, the bone quality. As you sit 24 hours a day, there's remodeling. Osteoclast will be eating up your bones and it will be filled up, patched by osteoblasts. So therefore, you don't feel it. And your bones are constantly undergoing this coupled remodeling. The problem becomes if there's uncoupling. There's a different ratio. So example like this, osteoclast will work, osteoblast will fill up the potholes. If this is coupled, then your bones will remain normal. Okay, and this is bone mineral density, or what we call a DEXA test. This is a gold standard in terms of diagnosis of osteoporosis at the present time. Okay, it's measuring how much calcium is in your bone on the hip and on the spine. Why not the other parts? Because these are the weight-bearing areas and they're debilitating if they are not treated. Okay, so you care about the hips and also the spine. There are two scoring systems, T-score and Z-score. T for true, okay? Your bones being compared to somebody with the peak bone mass of 30 years old. The definition of osteoporosis is minus 2.5 or worse, okay? And the more negative it is, the thinner the bone. This is what we use for diagnosis of osteoporosis, the T score. Z, okay, the T, remember, is true. Z is for secondary osteoporosis. This is being compared your bone density to the same age, okay? So if your bones is unusually thin compared to people of the same age standard, then you must have some form of secondary causes of osteoporosis, like hyperthyroidism or hyperparathyroidism. It's normal bone architecture. This is the architecture of somebody with osteoporosis. Consequence, shrinking, kyphosis, what we call dough wager humps. They're at risk for fracture. Treatment of choice, first line is bisphosphonate, alendronate being the most popular one. These are anti-resorptive, they prevent osteoclastic action. Estrogen is also an anti-resorptive agent. SERM, the selective estrogen receptor modulator like raloxifene and tamoxifen, are considered anti-resorptive agents, so they prevent the action of osteoclast. Same thing with denosumab, is an anti-resorptive agent. The only anabolic agent is teriparatide. Teriparatide is a PTH uh, injection that we do every day, okay, and it will help build bones if you give it intermittently. So that's about it, and good luck on your exam.